The method of palpation is used in the examination of skin, muscle, and lymph nodes. Palpation is used to examine the physical characteristics of tissues and organs, and also topographical relationships between them. Palpation is also one of the important methods which is used in the diagnosis of disease of abdominal organs and the heart. Palpation of the heart. The palpation of the heart allows us to reveal hypertrophy and dilatation of the heart, and also the conditions of major blood vessels. The examination of left ventricle is carried out in the region of the apex beat. Firstly, the right palm is placed over the region of the apex beat to find its localization. Then, its strength and width is determined. In case of a hypertrophy or dilatation of the right ventricle, it can be palpated in the region of absolute dullness of the heart and the epigastrium. Inhale, exhale, incline forward. Cardiac beat is palpated during maximum expiration, while the epigastric pulsation is palpated during the deep inspiration. In a healthy person, the aortic pulsations are not seen. It is palpable at the second right intercostal space and sternal notch in case of an aortic aneurysm. In order to determine the diastolic murmur in the apex beat during a mitral stenosis, the patient is asked to lie on his left side. In the case of aortic stenosis, to determine the systolic murmur at the aortic point, the patient is palpated in a vertical position and slightly inclined forward. Abdominal palpation. The palpation of abdomen is done according to the principles of Vasiliy Promyovich Abrazov and also Nikolai Dmitrievich Strazinska. The abdominal palpation begins with a superficial palpation. The abdominal wall should be palpated symmetrically in both sides. Abdominal wall tension, painful points, and subcutaneous tissues are evaluated. In chronic inflammatory processes, the abdominal will be tense and a positive Schottky-Blumberg sign will be present. This method of palpation can also be used to reveal a hernia of linea alba. The second step is deep palpation of the abdominal organs. The localization, form, consistency, mobility, and the painful points of the organs can be evaluated by this method. Firstly, we examine the sigmoid colon, followed by the cecum, the transverse colon, the ascending colon, the descending colon, and also the stomach. In the deep palpation, there are 4 important moments. Firstly, it is the placement of the hand over the skin. Second, make a skin fold. Third, pressing into the abdominal wall. And fourthly, palpation of the internal organs. Hand placement, making a skin fold, deeply pressing into this abdomen, palpation. The cecum is palpated in the same way too. placing of the hand, making a skin fold, deeply pressing into the abdomen, palpation. In order to decrease the abdominal pressure by the Abrasov method, the left hand compresses the abdomen above the umbilicus. Before the palpation of the transverse colon, the lower border of stomach is needed to be determined. This can be done by using the method of succussion, whereby a splashing sound can be heard. Normally, the lower border of the stomach is localized 3 to 4 cm above the umbilicus. The lower border of the stomach can also be determined by the auscultate friction method. The palpation of a transverse colon is done 2 centimeters below the lower border of the stomach. The skin is moved upwards, press deeply into the abdomen, and palpate the intestines. Placing of the hand, making a skin fold, pressing into the abdomen, and palpate. Palpation of the ascending colon and descending colons are done by using the method of bimanual palpation by Vasilenko. Placing of the hand, making a skin fold, pressing into the abdomen, and palpation. Palpation of the stomach is done on the line of the lower border of the stomach and also the greater curvature of the stomach. Before the liver palpation, the lower border of the liver has to be found firstly by percussion method on the mid-clavicular line. The hands of the patient are placed on the chest. The left hand of the doctor is placed on the right side of the patient to fixate the rib cage, and the liver is palpated during deep inhalation. Right hand of the doctor makes a skin fold. On exhalation, the doctor presses into the abdomen, and on inhalation, the lower edge of the liver is palpated while palpating. Placing of the hand, making a skin fold, pressing deeply into the abdomen, and palpate. The palpation of a spleen is done also by the same way. The patient should be lying on his back or on his right side. The left hand is first fixated under the rib cage, the right hand put under the left costal arc. A skin fold is made, press into the abdomen, and palpate. During a bimanual palpation, it can also be used to palpate a kidney. On exhalation, the right hand of the doctor is pressed in, and on inhalation, the lower pole of kidney is palpated. The doctor places his hands on the patient, approximation of both hands on exhalation, and palpation of the lower pole of kidney. There are different methods of percussion, but the one we use most oftenly is finger-by-finger percussion. It is known that a dense organ gives a dull sound. An air-containing organ, such as the throat space, gives a tympanic sound. The clear lungs give a tympanic sound. This sound can also be heard from the back, under the scapular angles, and in the axillary region. In superlight percussion, the sounds will penetrate 2 to 2.5 cm. In light percussion, 3 to 4 cm. Loud percussion, 5 centimeters. In order to reveal pathological changes in the lungs, the method of comparative percussion is used. The chest is percussed on the intercostal space symmetrically on both sides. This is done first in the front of the chest, and lastly at the back. In a healthy person, the percussion gives a clear resonant sounds which are heard symmetrically on both sides. Dull or dulled sound of the chest can be revealed in a case of inflammatory processes in the lungs, or accumulation of fluids in the pleural cavity, such as hydrothorax. Tympanic sound can be heard when the air is accumulated in the pleural cavity, which is known as pneumothorax. Or in the presence of a cavern or abscess in the lung. In order to determine the lung border, we use light topographic percussion. Let's see how to find out the lung mobility. First, we find the lower border of lungs in normal respiration. Then, find the lower border of the lung in deep inhalation. And lastly, we find the lung border in deep expiration. The normal lung mobility is 6 to 8 centimeters. Percussion of the heart, it starts by localizing the relative dullness at the right border of the heart. To do this, we have to find the lower border of the lung first. Then, we move up one intercostal space and continue finding the right border of the heart. Left border of the heart is determined by percussion on the 5th intercostal space. Upper border of the heart is determined 1 centimeter laterally from the left sternal border. After that, we find the border of vascular bundle at the 2nd intercostal space. We then continue to determine the contours of the heart at the third and fourth intercostal spaces from the left and the right side of the heart. Connection of all these points will allow us to have the contour of the relative downers of the heart. The shift of the right border corresponds to the dilatation of the right atrium and the right ventricle. The left border for the left ventricle and the dilatation of the left atrium corresponds by the increase of the upper border. To define the boundaries of the absolute downers of the heart, we start percussing from the point of the relative downers by using light percussion. Thus, the right, the left, and the upper border of the absolute dullness are found. When these points are connected, we will get the size of the absolute dullness of the heart. The increase of its size is observed in the dilatation of the right ventricle. Percussion of the liver. To determine the absolute dullness of the liver, percuss along the right parasternal line using light percussion. Normally, it is found in the 6th ribs. By the same way, the upper limit on the mid-clavicular line is found on the 6th rib, while for the anterior axillary line, it is on the 7th ribs. Then, we find the lower border of the liver by percussing on the right parasternal line. This is found 2 centimeters below the costal arc. The lower border of the liver on the mid-clavicular line is found on the costiac, while for the anterior axillary line, it is on the 10th rib. The lower edge of the liver on the anterior midline is found on the upper and the middle thirds of the distance between the umbilicus and the xiphoid process. For another size of the liver, it is found along the left costal arc from the left parasternal line. With these marks, we now have 3 sizes of the liver. From the right parasternal line, normally it will be 8 to 10 centimeters. For the mid-clavicular line, it will be 9 to 11 centimeters. And for anterior axillary line, it is 10 to 12 centimeters. Auscultation. Auscultation is an essential method for the diagnosis of the disease of the lungs, hearts, and blood vessels. Usually, by direct auscultation, we cannot hear any pathological sounds and diagnostic sounds. To help auscultation, we can use a stethoscope, phonendoscope. With these instruments, pathological processes in the chest can be localized more precisely. Auscultation of the lung. During auscultation of the lung, we have to pay attention to the main respiratory sounds. In a normal situation, we can hear a vesicular breathing. Please remember this sound. They appear during inspiration and 1/3 of the phase of expiration. Vesicular breathings can also be heard in the axillary and subscapular region. On the throat and the trachea, we can hear bronchial breathing. This occurs due to the air flowing through the glottis. It has a more rough character and sounds like the letter H. Pathological weakening of vesicular breathing occurs due to the presence of fluid in the pleural cavity. In inflammations of the lung, we can hear bronchial breathing. In the presence of abscesses in the lungs, amphoteric breathing sounds can be heard. Besides the changes in the main respiratory sounds, we can also listen to additional respiratory sounds in the lungs. Now, we can hear dry rows in the patient during an attack of a bronchial asthma. They occur due to the result of a spasm of a bronchus and also presence of exudate. Presence of watery secretion from the bronchus. We can hear bubbling rows. In the presence of small amounts of watery secretion, we can hear crepitation. This occurs due to the expansion of alveolar walls during inspiration. Auscultation of the heart. The auscultation of the heart begins at the apex beat. To determine and differentiate between the S1 and S2, we can place our fingers over the apex beat or the pulsation of the external carotid artery. We then listen to the aorta, the pulmonary artery, the tricuspid valve, and lastly, an additional point known as Botkin-Earp point. For a clearer listening to the aorta, it is necessary to incline the patient forward in a vertical position. During a mitral valve pathology, it is clearer to listen to the patient's heart sounds by turning the patient to the left side. In norm, on the apex, S1 is louder than the S2. S1 consists of a few components: the valvular, the muscular, and the vascular components. It is formed as a result of closing of the atrioventricular valves, contraction of the muscles of the ventricles, vibration of the pulmonary artery, and aorta at the beginning of systoles of ventricles. In norm, at aortic point, S2 is louder than S1. S2 is formed by the closure of the aortic and pulmonary valves. First heart sound, second heart sound. First heart sound, second heart sound. In mitral valve insufficiency, we can listen to a weakening of the S1 and a systolic murmur, which is located at the left mid-clavicular line. It is present as a result of a regurgitation of the blood from the left ventricle to the left atrium. S1, murmur, S2. S1, murmur, S2. In a mitral stenosis at the apex, we can listen to a snapping sound and also a diastolic murmur. Murmur arises as a result of difficulty of blood passing through the mitral valve. S1, S2 with murmur. S1, S2 with murmur. In mitral stenosis at the pulmonary artery point, we can listen to an accentuation and splitting of S2. This is formed due to the increase of pressure in the pulmonary artery and also closure of the both valves at different times. S1, S2, S1, S2. In aortic stenosis, the weakening of S1 and S2 and the presence of a loud murmur in the aorta that radiates to the carotid artery can be found. The murmur appears as a result of the narrowing of the aorta and the difficulty of the blood passing from the left ventricle to the aorta. In this video, we have taught you some physical methods of examination of a patient, which includes the palpation, percussion, and auscultation. Although there are many modern diagnostic tools and laboratory investigations, these methods such as palpation, percussion, and auscultations still remains the basic method of investigation.